Right, so thank you, Chris, and I'd like to thank the organizing committee for this wonderful day, and I'm actually privileged to be here. And it's great to see such a big, turnout, and I always like to connect with patients and caregivers as well. So it's a great opportunity, for me today as well. So obviously 15 minutes, 20 minutes, not really, enough time to cover, the entire subject of radiotherapy, but I'll do my best to try and cover some of the important aspects of radiotherapy, especially for brain tumors. I'll briefly touch on the principle of radiotherapy, and then I'll talk about some types of, common brain tumors that we encounter and that their, standard management paradigms these days. Cover some of the side effects of radiotherapy, and just a slide or two on advanced, radiotherapy techniques, and briefly touch on some of the local clinical trials that Wellington Hospital is currently involved in. So, I mean, not like neurosurgery, we don't go back 10,000 years, but we've been around for 100 years now, and we've come a long way, and radiotherapy has been extensively studied. And now it's an extremely safe and it's a precise treatment modality for cancers. And we use high energy X-rays to damage cancer cells' ability to grow and divide. So ultimately killing the cancer cells over time. And it remains a fundamental treatment modality for brain cancers. And there are multiple professionals involved in the process, not just radiation oncology people, but also radiation therapists, medical physicists, and also allied health professionals, all getting involved and working together and going through a robust planning process, a lot of quality assurance, some checks and image guidance throughout the treatment. And it is often used alone for brain tumors or in combination with surgery and or chemotherapy. So what is a brain tumor? I mean, there are primary brain tumors, meaning that they originate in the brain, and these consist of both benign and malignant tumors. They can be gliomas, meningiomas, pituitary adenomas, and costinomas, just to name a few. Then there are secondary brain tumors, and these are known as metastases. That means that these actually spread from a different source in the body to the brain, such as lung cancers or brain cancers, and so on. But obviously, our primary focus here today will be primary brain tumors, and gliomas is a broad category that includes glioblastomas, oligodendrogliomas, and astrocytomas. Now, before 2020 or 2021, gliomas were classified largely based on their appearance under the microscope. But over the years, its classification has changed as we know more and more about these tumors, in particular their genetics and molecular information. So nowadays, we actually classify them based on not only on their appearance, but also their genetic makeup, and pathologists are providing us a layered report structure. And this allows better understanding of each tumor type and also help us clinicians individualizing patients, for individualizing treatment for patients. Now, there are lots of different markers and genetic information and molecular information, but probably the most important things to note would be IDH mutation status, where you have mutated IDH mutation. That generally means a better prognosis compared to IDH wild type. And we have also one P19Q co-deletion status. So if you have one P19 co-deleted, then it's oligodendroglioma associated with better prognosis, whereas a non-co-deleted means astrocytoma, and the prognosis is unfortunately not as good as that of oligodendroglioma. So the classification is it's changing all the time. It's evolving, and it's quite complicating. And I still get confused, every time I look at it. But it's great to see because it does actually help us tailoring treatment for each individual patient. Now, glioblastoma is the most common primary brain tumors in adults, and it has, as we all know, it's got poor prognosis with the median survival of 14 months. And each time I see this MRI image, my heart still sinks. unfortunately. And many of you already know that we treat GBM, glioblastomas with standard 6 weeks of radiotherapy and chemotherapy, followed by another 6 months of chemotherapy using temozolomide. So temozolomide is a chemotherapy of choice for glioblastoma. It's an alkylating agent that does get to the brain, and it disrupts DNA structures and kills the cancer cells. It's the trial by Stubbs back in 2005. That's the landmark trial that really defines the current treatment paradigm for glioblastoma. And there are lots of ongoing studies, looking at new drugs and novel therapies, but unfortunately, there has been no real groundbreaking studies since. Patients with glioblastoma treated with a combination of radiotherapy and temozolomide had improved survival by approximately 2.5 months, compared with those who only had radiotherapy alone. Now, MGMT methylation status is a very important marker that predicts better response and also longer survival. So if you have methylated cancer, methylated tumors, then these tumors are less able to repair the damage done by the tablets, the temozolomide tablets. Therefore, patients with this, particular mutation, live longer, and they respond better to the chemoradiation treatment with the median survival of approximately 22 months. Now, there has been considerable uncertainty around the optimal management of older patients with glioblastoma. First of all, the length of such standard treatment schedule, 6 weeks may be too long for them. And elderly patients, as we understand in general, their overall survival is somewhat less than the younger, patient with glioblastoma. So you start to wonder, okay, so is the 6-week course with radiation and chemotherapy, can patient actually tolerate? They may not due to other, regions such as frailty and other medical conditions. So there has been a lot of studies around that, including the recent one in 2017-16. And now we offer, based on these studies, we offer the shorter course of radiotherapy, the 3-week course of daily treatment plus temozolomide for these elderly patients. And this shortened course demonstrates similar survival rates and quality of life. And if you obviously have MGMT methylated status, then you would likely to do better from radiation and temozolomide just for 3 weeks only. Now, but not everyone or not all elderly patients can have this shorter course of radiotherapy and chemotherapy because they may not be well enough to even tolerate the short course. And we consider then other options such as radiotherapy only, temozolomide alone, or supportive management. So it's an individualized approach, and it's really important for us to see the patient and assess and discuss pros and cons and benefits versus risks to make that decision. Now, high-grade gliomas unfortunately always come back, and treatment after recurrence is a tricky one, as there is less consensus about the potential benefits of treatment when this happens. It's important to note that treatment of recurrent glioblastoma does not always improve survival compared with supportive care alone, such as managing symptoms using steroids and dexamethasone. Therefore, it has to be an individualized approach where risks versus benefits are clearly discussed and reviewed and assessed. And there are multiple factors to consider before we make that decision, such as how soon did it come back? How extensive is it now? Where is the recurrence? How well is the patient? What type of glioma was it originally? And so on. So depending on these factors and after discussion with patient and family, their options include re-resection. So often we consult neurosurgeons for possibility of going back. There's an option of re-radiation using various modalities of radiotherapy. There's an option of chemotherapy, trying temozolomide again, or second-line treatment such as PCV. And then there's targeted treatment like bevacizumab, and of course there are other novel therapies in development and there are ongoing trials and studies for this. We always discuss these cases at our local tumor board, our multidisciplinary meetings to go through the imaging and discuss cases and come up with the best possible management for each patient. Now, WHO grade 3 gliomas are referred to as anaplastic gliomas. Now, while the updated molecular classification we saw earlier on has given us more insight into different subtypes, the general treatment paradigm still includes maximal safe resection, followed by radiotherapy and chemotherapy. For astrocytoma grade 3 anaplastic astrocytoma, the Cadmon trial has really demonstrated the benefit of temozolomide, hence it is generally accepted as a chemotherapy of choice. For oligodendroglioma grade 3, on the other hand, it is a bit contentious. So based on level 1 evidence, PCV chemotherapy showed survival advantage. Benefit of temozolomide in this setting is less clear and is currently being compared on the trial called CODEL. But many clinicians already substitute temozolomide already because it's easier to administer and it's better tolerated by patients. It's important to know, however, currently in New Zealand, a drug called lomustine, which is a component of PCV chemotherapy, is no longer available because the company stopped its production completely. So Pharmac did widen the access to temozolomide for all glioma patients, so not just glioblastoma, since I think October last year or November last year. So we are prescribing temozolomide for even low grade or high grade or glioblastoma patients. Now some hospitals still have some stock available, but depending on which DHB you belong to really. I'm not entirely sure when Pharmac will get the new supply of lomustine. Talked to pharmacists not long ago, but they haven't actually heard anything. So they've no updates at this point. Now, for low-grade gliomas, WHO grade 2 gliomas, the optimal treatment still remains controversial. The current established treatment paradigm remains largely based on clinical factors, and it requires patient-specific decision-making. And the key is really balancing the benefits of treatment against potential complications of subsequent treatment. We generally try and determine if a patient has a high-risk or low-risk disease after surgery, looking at various factors. Even then, there's really no consensus definition of low-risk and high-risk patient, because various studies over the years have defined risk factors somewhat differently. In saying that, some of the risk factors we commonly look at include whether there is any residual tumor after surgery, the age more than 40, the original tumor size, such as more than 5 centimeters, whether it was crossing midline at the time, or certain pathologies like astrocytoma. And if multiple risk factors are present, then we offer immediate treatment after surgery. And if you were to have immediate treatment after surgery, then it's better to have radiation and chemotherapy confirmed by a randomized controlled trial demonstrating better overall survival with the combination treatment. But then again, the question of PCV or chemotherapy, PCV or temozolomide still remains unanswered. Although I said earlier, many clinicians in different centers choose to give temozolomide instead of PCV. Now, some of you may have heard about this new drug called vorasidenib for low-grade gliomas. Now, this study published last year, and while it sounds promising and very exciting, there's still a lot of work to be done. And it requires ongoing discussion where this medication actually fits in the management of low-grade glioma. It's still not approved by FDA in the States, so I guess it will be quite a while before we actually can get access to this medication here in New Zealand. This new medication improved progression survival, which means it prevented the cancer from progressing, thereby delaying the time to the next intervention, such as radiotherapy. The overall survival data is not yet available, and it did show some increased side effects. I think it has some liver toxicities and other side effects. And now we've got this trial, and the question is, what now? I mean, the approach to patients with low-grade glioma is constantly evolving, and soon we may actually have not 2, but 3 options for patients after surgery, whether it's watchful waiting, radiation and chemotherapy, or this IDH inhibitor for vorasidenib. So let's watch this space. Now, when it comes to side effects of radiotherapy, we usually break them down to short-term, medium-term, and long-term. Short-term side effects occur during and shortly after treatment, lasting a few weeks, and most of them will gradually go away. They are reversible and temporary. Medium side effects, typically weeks to 2, up to 2 months, which tend to, again, gradually disappear. And then we have long-term side effects, which can occur months or years down the line. Some of these effects can be permanent. And this is a nice sort of a diagram demonstrating some of the common side effects of brain radiotherapy, along with the timeline there. And obviously, the larger circles means a likelihood of getting side effects. The most common side effects include feeling tired, patches of hair loss, sometimes headaches and nausea. Those symptoms we can easily manage with simple medication and supportive management. There are other rare side effects such as seizures, altered taste, temporary hearing impairment, but these depend on what part of brain we're treating, how big the radiation area is, and also how much of the radiation dose is being delivered. Fatigue can also be a medium to long-term side effect for some patients, and if the tumor is near, say, pituitary gland, which plays an important role in managing hormones in our body, then you can get a hormone imbalance in later down the line, which may require ongoing endocrinology follow-ups and reviews and their support. Radiation can have effects on our cognitive function, such as short-term memory or complex problem-solving function. Again, this is dependent on the location of the tumor and the size of the radiation field and the dose, etc. And we radiation oncology clinicians are well aware of these side effects, especially on patients' cognitive function, because that's very important. And there are ways that we try to mitigate or prevent these radiotherapy side effects. But I cannot stress enough that supportive management, not just fancy medications or fancy techniques or machines, still plays a very important role here. Managing symptoms with appropriate medications, involving multidisciplinary team early, providing ongoing support, cognitive rehabilitation are all very crucial in managing side effects of radiotherapy. We can try and reduce radiation dose going to particular areas of the brain called hippocampus. Now, this is a paired structure in our brain that plays an important role in memory function. And by actively avoiding radiation dose to this part of the brain, we can lower the risk of radiation-induced neurocognitive deficits. There are some drugs that have shown to lower the risk of cognitive decline after treatment, and one of the examples include Memantine. This is a medication used for Alzheimer's disease as well. This has shown to reduce cognitive decline, but from what I understand, this is not unfortunately funded in New Zealand, but it is available. Now, I thought I'll just spend just a couple of minutes on some of the advanced radiotherapy techniques available in New Zealand or in Australia or other parts of the world. And these include TrueBeam machine, CyberKnife machine, and Gamma Knife machine. Now, these all sound really fancy, sounds like superheroes really. And these are tools for treating brain tumors, specifically for what we call stereotactic radiotherapy, which is a non-surgical treatment option that uses high doses of very precise targeted radiotherapy to destroy cancer cells, and patients usually only require a single treatment or just a few treatments over a week or so. Now, the typical question we get from patients is, now, which one's the best? I want to go with the best machine. And I wish I had a straightforward answer, to this really, but it's actually quite more complicated than that, and quite frankly, can be really confusing because everyone will say their machine is the best, really. And each technique has its unique characteristics, and no one treatment platform can have all the ideal characteristics, really. And it requires, I mean, it's like giving someone a fancy Apple laptop. But if you don't really know how to operate or how to use it to your, to its maximal potential, then you're not going to get the best clinical outcome out of it. And good delivery system, a fancy machine is a crucial part of ensuring the success of treatment. But it is only one step in the chain, and successful treatment will need reliable, well thought out protocols, careful, patient selection, and also clinicians' expertise as well. Now, what about proton therapy? It's a massive treatment machine, almost the size of the building. It is probably the most expensive treatment, so surely should beat all the other, treatment machines. Proton treatment has its unique physical properties. So as it enters the body, it has very low entry dose. And then it deposits most of its radiation dose onto the target. And then when the beam exits your body, it leaves, I mean, there's not much of an exit dose at all. So it can be really useful if you want to treat a tumor right next to a critical structure, and that tumor requires a very high amount of radiation that conventional machines cannot achieve, cannot deliver. Proton therapy has been established as useful treatment option for some pediatric tumors, sarcomas of the skull base, or chordoma, and these tumors require very high dose of radiation. Interestingly, however, the bottom one's not showing up there, but it has not been established as clinically superior in any adult solid tumors yet. There's been some studies, proton treatment for GBM, glioblastoma or prostate or lung cancer. They haven't produced anything clinically superior. Interestingly, the plan actually looked better, definitely with the proton treatment, but when it comes to looking at, cognitive decline, there's similar outcomes compared with conventional treatment, especially for glioblastoma. Now, I thought I'll just I made some last minute change to my slides and decided to add this slide in because I thought it would be important to share this with you. And I apologize in advance because it is depressing. And this report came out a few days ago, and it is truly shocking and alarming. And this survey was actually done by our college, Royal Australian College of Radiation Oncology, giving us some insight and trends from 2010 to 2020. Basically, we are falling behind in every aspect. The number of machines per million population should be increasing as the population increases. Now it's fallen to 6.1, where in an ideal high-income country, it should be 7. So that means we need at least 5 more machines around the country. More than half of our machines are old and due replacement. Workforce remains the most difficult challenge for us, and the number of radiation oncologists grew only by 9%, from 41 doctors to 45 doctors in the whole country. During the same time, Australia saw a 25% increase. Queensland, the state with the similar population to New Zealand, the number of radiation oncologists grew from 44 to 60 during the same time. Survey by the Specialist Union, ASMS, done in 2020, showed radiation oncology as a specialty with the highest burnout scores. So it's scary, and it is true. And we are really hoping for a change, big change to come to improve our current position. And all the stakeholders must be aware of the risk and act together now. But we got to start somewhere. Already some of the radiation oncology departments in the country are struggling to keep up even with daily, routine clinical workload, let alone research or trials. But we got to start somewhere, and these are not fancy international studies. But these are some of the local trials that Wellington Hospital is currently involved in. So the first one is a metabolic therapy program for glioblastoma. Essentially, this is a ketogenic diet program that's in conjunction with the standard treatment for GBM. It's a phase 1 trial, meaning it's experimental. It's a safety trial. So basically, that we're trying to see if it's safe, and whether it works or not, it's a bonus really. And the key investigator is Dr. Matthew Phillips, neurologist based at Waikato. We are recruiting patients in Waikato and Wellington regions, and patients with new diagnosis of glioblastoma who are eligible for the standard 6 weeks of radiotherapy and chemotherapy. The second trial is a local trial, again led by Professor Sui Tan and Mr. Agatha Wicks, a neurosurgeon. This is a phase 2 trial by GMRI and Gillies McKindle Research Institute. And this is quite interesting because they're using a repurposed medications, the medications that are commonly available in community. And patient will still go through the standard treatment for glioblastoma, but they are adding in combination of commonly used medications. Again, this is a phase 2 trial. They are accepting, I think they're not officially open yet, but we are referring patients to the institute. This is basically it would be patients with new diagnosis of glioblastoma after surgery and chemoradiation. In the initial phase would be eligible for this trial, and we do refer patients to these people. And we always discuss these cases, these trials with patients with glioblastoma. That's it, really.